When patients first come to the radiation oncology department, we like to introduce them to several members of the staff. Usually, of course, they meet the front office staff first, and even there, patients tend to get a warm welcome. The nurse takes them back to the exam room or consult room, as the case may be, and spends a little bit of time getting some of the basic information that we need. But then on a consult day, they may see the physician assistant, Helen Moore. They would also have contact with me for quite some time. During consultation, we usually spend somewhere around about an hour to sometimes a little bit longer with patients, depending upon how much information they have about what problem they are experiencing, their disease condition, whether or not anybody's discussed x-rays with them, whether or not they really have a good understanding of why they're here to see us. I like for patients to really understand the details of why they're with us and what to expect from what we're offering in terms of treatment for their cancer. Radiation therapy is very detail-oriented. We have a very large team, actually, of professionals that are specifically trained in certain areas. We have the therapists that are dedicated to giving the treatment every day, a very detail-oriented position. They have to get the person into the exact same position every day within probably about 3 or 4 millimeters of tolerance for day-to-day positioning. That's the team that the patient actually sees every day. Most times they don't have to see me every day, and that's probably good, because when they see me, it tends to take a little bit more of their time. Several members of the team are totally behind the scenes, the physicist and the dosimetrist. These two persons work in a special area that we call the physics lab. They operate the computers. They make sure that the quality assurance is completed every day, every week, every month. They transfer the data back and forth to all of the computers that we have in the department. They are also responsible for the checks on the machine, the linear accelerator that gives the treatment, to make sure that it is doing exactly what we think that it's doing. Each patient has a CT scan for treatment planning purposes. This CT scan is given without contrast generally. That's what the patient often calls a dye. They usually don't have to have injections, they don't have to skip meals, they don't have to drink anything for our CT scan, and yet our CT scan is extremely detailed. The slices of the scan itself are only 2.5 millimeters, so a very, very close cut, and we can see with a lot of detail the anatomical situation within. And then I can compare that back to the diagnostic CT scans, PET scans, and other x-rays, and from that I can create a situation in the computer that shows in three-dimensional form the tumor within the patient, and then on the computer we actually apply the radiation beams, and we can then transfer that data to another computer and enter the information regarding the radiation itself and know exactly how much radiation is given to every part of their body. I often tell patients that we've made a lot of strides in radiation therapy over the 18 years that I've been in this field. The radiation is actually exactly the same as it was when I started 18 years ago, but the detail with which we give it and the accuracy with which we can send it into the patient and the knowledge of exactly what we're hitting and how much radiation is being given is dramatically different than it was 18 years ago. In fact, we've progressed to a significant extent in just the last 5 years with what we are able to do. Part of the reason that our capability has been enhanced is because of the new equipment that we have now, a linear accelerator that has what's called a multi-leaf collimator system. And using this, we can give a type of radiation or an approach to radiation that's referred to as intensity modulated radiation therapy. This isn't appropriate for every patient, but there are a lot of patients that benefit from a very refined and confined dose to a particular part of their body as opposed to a large field. There are also, of course, certain situations that a large field of radiation is the exact thing that the patient needs because of the risk of microscopic cells over a fairly large area. These are the kind of things that I analyze most of the time before and during consultation and try to explain to the patient so that they're able to understand why we're doing what we're doing.